Do they look? Do they look okay as they are? Do I need to go to a?
I think this is okay. Yeah.
Okay, good.
Yeah.
Good. So this is a good way for me to do it. So thank you very much, Catherine. So I'm Tim Block, and as you see on the slide, and the title of my talk is Chronic Hepatitis B, is a cure possible and is a cure necessary? And I'll try to answer both those questions in this talk. I'm the co-founder and president emeritus of the Hepatitis B Foundation. I'm currently a visiting professor at Yale University for this year. And these are my conflicts, but enough about me. What I'll do is answer this very lofty question here, and you can see my pointer, I think, right? And I'll talk a little bit about Hep B Foundation. I don't think that's very necessary. Talk a little bit about the problem of hepatitis B and liver cancer. That's not so necessary. Just I have a couple of the obligatory slides. But what I really want to do for you today in the next 25, 26 minutes and answer questions, if there are any, is outline the current and investigational drugs that are out there. And I'll tell you what I think the next new drugs that will be available for use in the next years are. This is obviously my opinion. And talk a little bit about how they work, and that'll mean that we have to talk a little bit about the virus life cycle. But first, the obligatory slide. I think maybe everyone knows about the Hepatitis B Foundation and a little bit of some of the services that are carried out. You're obviously familiar with the ECHO and Hep B United, but the foundation. This is our website, and this homepage is probably one of the most visited portals of entry for information about hepatitis B in the world. And on it, you can access many resources. One of them is the Drug Watch, which I'll refer to if you haven't seen that. I have a reproduction of it coming up later, but it's a great resource. We hear about it all the time. Lists all the now more than 40 known investigational drugs for chronic hepatitis B. We have another one for hepatitis D, and also I'll talk a little bit about Liver Cancer Connect, which also talks about the liver cancer drugs. Hepatitis B Foundation is the coordinator of the definitive hepatitis B meeting, molecular biology of hepatitis B, that just ended in Paris a couple months ago, last month. We host field moving workshops where we bring experts together, like many of the people on this call, to really move the field. And we just had one in September on whether or not guidelines for treating hepatitis B should be, this is chronic, CHB is chronic hepatitis B, should be expanded. A lot of outreach and advocacy. And of course, you know of our US FDA Hep B patient conference. Not to be crass here, but we also, the foundation created a discovery institute called the Baruch S. Blumberg Institute that is working on cures for hepatitis B, D, and liver cancer. And when we do this with faculty from universities around the country, even world, we've spun out several companies. And you know, while I have your attention, I want to say that the Hepatitis B Foundation sponsored research from the Blumberg and its past institutes is responsible in part for many of the new drugs that are in trials today. The CAMs, or capsid inhibitors, have their origin at the Blumberg Institute, what were initially called the IHBR, from the labs of Jutao Guo. The new RNA degrading molecules can come to us, and the siRNAs. I bet no one on this call knew this because this shocks everyone. I'll tell you what the siRNAs, but they're probably likely to be approved for use in the next couple of years. The first siRNAs, gene silencing RNAs, started with Blumberg scientists. We were called the IHBR at that time. And we have these micro VC funds and then a slightly bigger VC fund for directed at basically thematically liver, our kind of drug discovery startup companies. So we do entrepreneurial and we do patient advocacy. And I spent more time on that than I intended to. So I now have to shortchange all the hundreds of millions of people with chronic hepatitis B. You know this slide. This is what hepatitis B is. You've seen it. It's largely a problem of Asia and Africa. But in the US, there are 1.5 to 2 million people who have chronic B as well. It's a problem in 20 or 30 countries, a significant problem. And it's a problem because Hep B, as you know, is the primary etiology of liver cancer, hepatocellular carcinoma in the world. And liver cancer is a problem in the same places that hepatitis B is a problem: Asia, South Asia, Africa. It's also a big problem in the United States too, with 30, 40,000 cases a year, maybe even close to 50,000 of liver cancer, but of those, about 10,000 are associated with hepatitis B. The rest, obviously, other causes. Take a look at the Liver Connect website. The Hepatitis B Foundation maintains a specialized portal of information for liver cancer. It's such a big problem for people with Hep B and Hep D, and the Cancer Connect Drug Watch as well. Very, very important resource, as is our patient referral service, something for the caregivers on the call to be mindful of, and the patients around the world. In the US, this is Bob Gish's slide, so if he's on, I'm glad I acknowledged him, because it tells you what the problem of Hep B in the US is. The prevalence is, we put it, officially it's between 800,000 and 2 million. We put it at about 1.5 to 2 million. And some of the studies the foundation's been involved with really buttress these numbers. Let me now spend a moment on hepatitis B, the etiology of chronic hepatitis B and primary liver cancer. And I'm only doing this to explain briefly, so we're familiar with the biomarkers. Those are the lab values, the markers that the doctors look for when they're looking at someone's blood and they suspect hepatitis B, and show you where some of the drugs work. So this is a very crowded cartoon of the life cycle of the virus. I'm not going to go into all of this. What I want to show you here is just the virus. This is a picture of the virus. It's shown over here as well. What I ask you to know about the virus at this point is, in the middle of the virus is DNA. That's the virus's chromosome. It specifies all the what are called gene products of the virus. It is the definition of viremia. So virus in the blood. Here's the blood here, right under this red line. This is the cell. This is the blood, and virus in the blood is viremia. And what's being detected is viral DNA. It's this piece of DNA here that's in the virion. That's what the International Genomes Per Milliliter, that's what they're talking about. And that exists in the blood of people who have chronic hepatitis B. That's pretty much a definition. But the actual definition of chronic hepatitis B is a sampling of a blood that's positive for this particle, hepatitis B surface antigen. That's the virus envelope protein, just big polymers of it, free of the virus, in the blood of someone with chronic hepatitis B at 2 samplings, more than about 3 months apart, let's just say. That's kind of the standard. This protein here is on the surface of the virus. It's called the L, M, and S protein, large, medium, and small surface antigen protein. And that is the definition. That is what surface antigen is. That's what we're talking about. It's the surface antigen that allows the virus, shown here, to attach to the surface, the plasma membrane of the hepatocyte, the liver cell. It attaches here, it goes in, and then all the business of the virus starts. The other point that you always hear about is cccDNA. That's basically this DNA here from the virus, now closed. It's closed together, glued together in one form, and that's called covalently closed circular DNA. And this stays in the hepatocyte really for the life of the hepatocyte, shooting out all the viral gene products. That's what this crowded thing is here. I'll call your attention to some of these points in the life cycle a little bit later. But for us right now, viremia is viral DNA in the blood. It's the virus, the infectious virus particle. And what's measured, and we talk about it all the time, is the surface antigen. Of course, core is this triangle here, not triangle, hexagon here, and that's the core protein that is basically the brick house that the viral DNA exists in. So, that's the illustration of life cycle of the virus. But what's measured, and the definition of the natural history of chronic hepatitis B, as it's called, is actually, these are the lab values that we just talked about as a function of time, years of infection. So someone is born with hepatitis B here, or shortly after they're infected, they become chronic carriers or chronically infected, chronic hepatitis B. And then this is simplified from Harry Jansen. The life cycle, the natural history of the disease is more complicated, but it really boils down to these kind of 3 phenomena. That is a tolerant phase where there's a lot of hepatitis B DNA in the blood. There's a lot of surface antigen in the blood, and the ALTs, that's transaminase, may be high or low. These begin to spike at some time, and that's active hepatitis. And you're seeing the DNA is going up and down, surface antigens going up and down, maybe declining. This is idealized. And ALTs are going up and down. These are the transaminases. That's showing that there's actually inflammation, hepatitis. The host is recognizing the virus, but not getting rid of the virus. Eventually, in the idealized form, this kind of rests, and there's immune control, and viral DNA is much lower. This is showing really very low. S antigen is lower, and NALT is kind of stabilized. Maybe they're a little elevated. Maybe they're back to normal. Normal would be very, very low. Now, the important thing here is the guidelines call for treating only this category of people. That is basically elevated DNA in the blood and S antigen in the blood and elevated ALT in the blood. We're going to talk about whether or not those guidelines are a little too narrow, whether these people should be treated and these people should be treated. And that will depend on the kind of drugs that are available. So so what does the cure mean? What does it mean to say that someone is cured? I'm going to give you my definition, the definition I've recommended for the Hepatitis B Foundation. And as a patient advocate, what I think is important. Come on, a real cure is when you return an individual with chronic hepatitis B to the risk of liver disease that an age-matched individual who has never been infected has. That is basically what I'm looking for. That means that suddenly I don't have any more risk of dying from liver disease than you did if you were never infected. And if you want to make that a little more qualified, at least a risk of someone who's got a resolved infection, which is a little bit more elevated than someone who's never been infected. And this definition here, returning to a resolved infection, is considered really laudable, but unrealistic. Or how would you ever measure that? So because it's so impractical to actually measure, quantify this as a risk, the field has come up with this definition, functional cure. And we can quarrel over and argue whether we think that's fair or relevant, but a functional cure just means here's the virion again. This time I've added antibody to HBsAg. This is the envelope SAG on the surface. So a functional cure really means that now there's no S antigen in the blood anymore. There's no viral DNA that can be detected, certainly no core, and surface antibody. Now we're beginning to detect that, some argument whether or not that should be part of the definition, and ALTs are normal. That's a functional cure. So all the lab values of the virus are basically undetectable, and liver transaminase is evidence liver disease is normalized. This we feel is achievable and measurable with the tools we have now. The definition I give you, which is really a clinical definition, that's really what we want. I hope this is a surrogate for that. Okay, so there are drugs out there now. Can they do that? There are 7 medicines out there approved for use, the 2 interferons that are out there, and the 5 or 6 polymerase inhibitors, depending on how you want to count them. These are the nukes, the polymerase inhibitors. And these are the different organizations, the ASLD, ESOL, APASL, that have come up with guidelines for use of these drugs. And as I told you, they all basically, even though they may differ on the precise values here, they all basically say, treat only people who have elevated DNA, elevated ALT, and obviously have S antigen in them. So how's that working out? Well, right now, this comes from our president, Sherry Cohen, and her publications, showing you right now that let's just look here, of all the people in the world who have chronic hepatitis B, it's estimated that 8 to 10% of those 60 million people know they have hepatitis B. So right away, we got a lot of work to do. There are a lot of people there who have hepatitis B. Most don't know they have it. That's not acceptable. But even if you know you have it, only 2% of the population, or 1/5 of this group, are treated. And in the different parts of the world, these differences between I know I have it and I'm being treated are really quite extreme. So even just grabbing these people, we've got a lot of work to do. And of course, that's what the Hepatitis B Foundation is dedicated to doing, finding these people who know they have hepatitis B, getting them treated if they need treatment, and certainly finding the other tenfold people, the other 240 million people who have hepatitis B but don't know they have it. So right away we know, okay, the drugs that are out there are not being used enough right now, and people are at risk. But even for the drugs that the people that are being treated, here's the group of people that should be treated. That's that Janssen slide. How many are being brought to this category? Functional cure. We'll call that S antigen loss. So this table here, it's a little old, but it hasn't really changed that much. Let's just focus on S antigen loss. These are the two populations, E positive, E negative. I'm not going to, for my purpose, we don't have to distinguish, but interferons, only 3 to 7% of the people who get treated with interferon achieve this functional cure. That's not many. And of the nukes, it's even far worse. Even this is even after years of treatment. Only 2 to 5% of the people who are treated with the nukes get functionally cured. So that's good and that's bad. Here's the answer to the question. Is a cure for hepatitis B necessary? Yeah, well, look at the number of people. We're going to talk about that. Is a cure possible? Yeah. I mean, this isn't very satisfying or sufficient, but 3 to 7%, and this number now in some studies is up to 10 and 15%, depending on patient selection, do get functionally cured. It is possible. It's possible right now with the appropriate use of the drugs that are out there. But is it necessary to go beyond that? So look at this group here. This I found, this was put together by Alison Evans, who was a part of the foundation's professor at Drexel, and other studies have now confirmed this. This is the likelihood that you will die or get liver cancer and die if you have chronic hepatitis B as a function of age over a 10-year period. So starting here, you're 30 years old. What's the likelihood that you'll be dead in 10 years of liver cancer? If you go to here at age 50 and you're in the treatable group, that is that middle group there that had the chatter with the ALTs high, DNA high, S antigen detectable. Look at this, your likelihood of being dead. I found this amazing. In 10 years, if you're in the treatable category and you have chronic hepatitis B, it's like 30%, and it goes up much higher if you're older in 10 years. So you definitely should be treated. And if you get treated, the likelihood that what that treatment will do for you, it lowers it. I put this in here. We now know the real numbers. This was years ago. It drops it by about 50%. So you can reduce your risk of being dead by liver disease by 50%. You won't be cured. You'll still have markers, but you'll reduce the risk of being dead by liver disease if you go on the current treatments, if you're in the treatment. That's pretty powerful. So yeah, it's necessary. Treatment is necessary. So I answered, it's necessary. But let's talk about this population here, what are called the untreatables, the people who fall outside the guidelines. This was put together by Allison 10 years ago, or close to 10 years ago, but a study that was done by Kim et al. Is getting a lot of attention, which it shows that Allison was spot on. Look at this study. This study of several thousand people. This red line here is saying, what is the likelihood that someone in the immune tolerant phase, that is the untreatable group, will be dead in 10 years by liver cancer? This is actually death. This is detection of liver cancer right here. And you can see here that Allison was right. Over a 10-year period, look at this. This is in 1 year, of course, no. 2 years, a little bit. 4 years, a little bit. 5 years. In 10 years, someone with in the immune tolerant phase will, the likelihood of them dying is between 8 and 12% from, of getting liver cancer is between 8 and 12%. Now that to me is, the screaming call for treatment. I know I don't have Bob Gish on the call, but he's one of the champions of calling for expanding the guidelines, because this group of people need to be treated. This line here is the group of people who are at risk and are in the treatable category and get treated. They get dropped, and you've got to get this group down here by treating them. That's what I'm saying here. So that is the justification for expanding the guidelines. So who is likely to get cancer in those groups? What host factors are most influential in determining whether or not someone will have an unfavorable outcome in terms of getting cancer who has chronic hepatitis B or benefiting from care? So your likelihood of an unfavorable outcome, including from treatment, is the older you are. That maybe is due to length of time of treatment. These are just graphics that are some of the papers that illustrate what I'm saying up here. I'm not going to talk about this. This is not time. These are separate talks. But it's just to basically buttress and give credibility to what I'm telling you, that, yeah, age is a big factor. And the older you are and have been infected, the longer maybe your T cells become exhausted and they can't respond anymore. Levels of S antigen. So this right here is probably one of the easiest things you can measure and determine whether or not someone will benefit, the likelihood that they will have a functional cure following a treatment. The higher the level of S antigen, the less likely. Genotypes, Brian McMahon has done a lot of work on this, showing that some genotypes are more virulent or more associated with poor outcome and refractoriness to treatment. Maybe ethnicity, but maybe that's related to genotypes and length of time of treatment. The microbiome and comorbidities, that's certainly become a factor. We can talk about that. And of course, very important, co-infections, D, HIV, less HCV, but D, HIV are very important cofactors in dictating likelihood of benefit from treatment and also affecting the natural history of the disease. So what are we going to need from a cure? Direct-acting antivirals that suppress viremia and antigenemia. Obviously, we've got a good backbone with the nukes. These are the polymerase inhibitors. They prevent the virus from replicating. We need something that's going to affect antigenemia, right? You've got to suppress S antigen. I think most people, most people in the field think that's important. And then, of course, what we don't have now are immunostimulatory drugs that help restore the host from suppressing virus infection, teaching so that we're not just dependent on exogenous drugs to repress viremia and antigenemia, but something to beef up the immune system. You've seen the value of interferons. We're looking at some of the value of these so-called checkpoint inhibitors. It's going to take some kind of combination that is going to, we're going to need some kind of combination. I'm falling over my own words. So, so what are some of these new therapeutics that we're going to need? Look at the Drug Watch. This is the screenshot from the Hepatitis B Foundation Drug Watch, and this obviously I don't expect you to see it, but it lists all of the 40 different, or now 45 different drugs in clinical trials. They're where they are in clinical trials, their mechanism of action, and their sponsor, the company or labs that are putting them out there. It's a very useful site. and I've just summed up here the difference between what was on our Drug Watch in 2009 and 2020. In 2009, there were only 14 drugs listed. 2021, they're now more than 49, maybe 50. And the number of drugs that are in clinical trial is also also quite profound. If you look at their categories, they're also spanning, as I said, they're spanning the direct-acting antivirals and the immunomodulators and things that just affect host function. We're going to talk about some of these right now and their mechanism. I'm running out of time, so I'm speaking a little quickly, but I like that they cover all kinds of categories of use. So I'm just going to now focus in on the drugs that I think are going to be available for use in the next 3 to 4 years. There are a couple direct actings, Hepatitis. Well, I was right about that. That's a receptor blocking drug that's now approved for use for Delta virus in Europe. I think it will be approved in the United States. It's also an anti-hepatitis B drug. The gene silencing siRNAs and antisenses, I think they're on the road to approval within the next few years. And some of the CAMs, these are the capsid allosteric modifying agents, capsid inhibitors. They work on the virus structural proteins. So Hepatitis, how does that work? Here's the virus. Here's the receptor the virus binds to. It's called the NTCP receptor. It's the bile acid transporting protein on the surface of every hepatocyte. Hepatitis B virus binds to that receptor. Hepatitis prevents that. It basically blocks the virus envelope protein. It's a form of the S called pre-S1. It's on the L protein, and it prevents that. It'll prevent hepatitis B virus from binding to the surface of the cell. It'll also prevent hepatitis D, because hepatitis D uses hepatitis B surface antigen to get in. So one drug prevents both B and D. It's very effective. Unfortunately, not a cure. It obviously is going to be needed to be in use with combinations, things that prevent hepatitis B virus from replicating, maybe something to do with hepatitis D. This is this cut from our Drug Watch. The other ones that you're going to see in use that are coming along very nicely in phase 3 clinical trials right now, siRNAs. these are drugs that, here's our screenshot from the Hepatitis B Drug Watch, Foundation Drug Watch. These drugs work on the hepatitis B virus messenger RNA. So here's the cccDNA of the virus. This, I should say, is a review that I wrote with Jutta Guo, and it's an annual reviews in virology, I think with Harvey Elter and Kyungmi Chang. And this is cccDNA, that the chromosome of the virus, and that makes messenger RNA, and that messenger RNA can be blocked with siRNA that is complementary to it. It binds to this, I've expanded it here, and then it gets degraded by what's called the RISC complex. And it's quite remarkable. It knocks down all the viral gene products. So siRNA is pretty impressive and pretty effective. It's got its problems. It's an injectable, as is Hepcludex, but it's very, very effective. I think it's going to be approved for use soon. The CAMs, capsid assembly modifiers, they've been a little bit more of a disappointment to me, but these are orally available drugs. That's a good thing. And they work here at the capsid formation step. Here you see the viral genome coming in. The RNA gets wrapped into the capsid, it gets turned into DNA. The virus then gets secreted from the cell. This prevents this process, the assembly process, or some of them cause the disassembly and degradation. Pretty interesting. Our drug watch shows at least 10 of these that are in development, 5 in clinical trials. I think one of them is going to be approved, and it'll be used in combination. There are other drugs that are out there in use, that in development right now. Probably farthest along are the checkpoint inhibitors, which are immune activators and very effective. We can talk about those in the discussion. They kind of take the brakes off the immune system. Got to be watched because they could have a downside, but a very part of a whole new family of drugs that we're going to need. Therapeutic vaccines are also in development, and of course a bunch of other things out here. The ones that I've got my eye on are the S antigen inhibitors, the NAPs. These do remarkable things. We need to see them reproduced by companies other than Replicor, but they're very impressive, their use. And of course, trendy new ones, CRISPR-Cas. Hepatitis B Foundation sponsored research at the Blumberg Institute's working on CRISPR-Cas, RNA degrading, HBs antigen inhibitors, and also mRNA vaccines through our spinouts. So my conclusion slide. Is a cure possible? Yeah, I've shown you that even with the drugs that are out there today, the nukes and the interferons, you can get 5, 10, and in patient selections, you can get 20 or 30% people if you choose S antigen low people for treatment using the nukes and interferon. 20 to 30%, you can achieve a functional cure right now with patients who are low S antigen. So yeah, a cure is possible. Is it necessary? Well, yeah, I showed you that people who don't get treated are much elevated risk for liver cancer. Certainly people who have elevated DNA and ALTs in their blood, no question about it. People have HDV co-infections, absolutely. So there's certainly populations that a cure is needed right away, but even people who fall out the current guidelines need to be treated. So the current guidelines are too limited. We're going to need viremia and antigenemia suppressors, and of course, the goal is really elimination of the disease. So that's my talk. Thank you for your attention. And I guess if there's time for questions, I'm happy to take them, or maybe the process is it gets opened up to a panel. Thank you.
Yeah.
I will close my slides.
Awesome. Thank you so much, Dr. Block. That was a really great talk, and you do such a great job at really simplifying really complicated process. So we certainly appreciate it. I do have one question to start us off, and I encourage others to insert things in the chat box if they have questions or raise their hand so we can just acknowledge you. So we do have a couple people living with hepatitis B on the line. I think some of the messaging may be a little bit, we've been talking about a cure for a while. What can somebody living with hepatitis B do, or what should our providers be telling people with hepatitis B do to make sure that they don't become part of the statistics of ending in liver cancer? If you have any suggestions or thoughts on that.
I'll give you my suggestions, but there may be other people or caregivers who want to say something. If someone has chronic hepatitis B, the first thing is almost all for everyone, of course it depends who they are, is that people should not panic. that there are now medicines there for people who fall within the guidelines, who clearly are the population of people who need treatment most immediately. And if you fall outside the guidelines, there you can be screened and monitored. So there are all kinds of tools now in the United States for sure, and even in the rest of the world. Of course, I would always ask questions about family members and vaccination and get that squared away. Then, of course, it depends on the individual's circumstances and in which risk category they fall into. But my first message is be seen by a doctor who knows about hepatitis B or a caregiver who understands hepatitis B, and know that this world today is vastly different than when we started the Hepatitis B Foundation, which were the dark ages. There are 7 medicines for use if you need them. And by need them, I'd say if you're in the most needed category, those are the people with the so-called immune-active hepatitis and other risk factors. And if you don't fall within those treatment guidelines, I'd ask your doctor about getting treated if they think that you should be treated, even if you're outside the official guidelines. And if you're outside the guidelines, know that there's surveillance that goes on right now, and you should participate in that. I see a hand went up.
Yeah, go ahead, Dr. Torgerson.
Hi, yes, thank you so much for that wonderful presentation. I wonder if you could comment on, with the newer agents coming out in our lifetime, of course, what patient populations in general do you think that these newer agents would be used over that are currently available nuke therapies?
Great question. So right now the justification for not treating people who are in the immune tolerant phase is their ALTs are on, and the justification for not treating people who have S antigen levels but very low DNA levels is, what can you do for them? We only have nukes. Some of the newer agents, like the siRNAs, and the ASOs, the antisense oligos, they address that problem. So they shut down all viral gene products. They will reduce S antigen. So there's really no virological justification for not using them in people who are S antigen positive, but maybe low DNA, or you didn't think they would be qualified, other than other disqualifying matters that you might want to say, well, they're very young and I want to start them on something, But so the siRNAs will suppress S antigen, they'll suppress core, they'll suppress X. Very importantly, they'll suppress X. We didn't even talk about that, but that seems to have an enduring effect on cccDNA. So that's the first one. My hope, but so far all the tests for all the clinical trials are in people who fall within the current treatment guidelines. So I don't know that most immediately things like CAMs will open the door to other treatment groups. But drugs like the siRNA inhibitors, checkpoint inhibitors, when they become available, they'll open the door for these other categories that are clearly outside the guideline categories right now. However, I want to emphasize that you're going to be hearing from me and other speakers, probably even like yourselves, knowledgeable people, that even with the nukes today, there's justification, we believe, for treating people who have DNA in their blood, but they fall outside the current treatment guidelines. But the new drugs, like the siRNAs, no reason not to treat S antigen positive anymore.
Thank you, Dr. Block. We had a couple of comments come in the chat box. First question, are we able to share your slides? I think some of the visuals that you provided were really helpful for people. Are you okay with us sharing that?
Yes, of course. And most of those figures come from papers and things, not that aren't mine. I hope the attribution goes along with it.
Of course. Yeah, thank you. We'll be sure to note that and share the slides with people. The first question is, with 60% of people in the US unaware of infection, do we need more providers to test hepatitis B, or is there another issue?
We published a paper on that a number of years ago. Yes, I think that I'm very hopeful that the CDC with the foundation's advocacy and other organizations are going to call for universal testing at least one time in your life to be tested for hepatitis B. And we will identify those 60 to 70 to 80% of the US population alone. that has hepatitis B but doesn't know they have it. It's the worst thing about having hepatitis B would be is that if you don't know you have it, if you know you have it, then you can do something about it. If you don't know you have it, it's, I don't want to call it a ticking time bomb, but obviously you're at a tremendous health disadvantage that you don't need to have. Yes, I think that during the COVID pandemic, the worst of it, almost every American, there were several 100 million blood tests done, obviously on COVID-19. We had proposed to the CDC that you risk stratify and test people at least at risk for hepatitis B. That was rejected. That would have been a great opportunity. I bet everybody on this call was tested at least once, if not twice, for COVID. It could have, everybody was. You could have tested for and I don't just mean for hepatitis B. That was a great opportunity to do a multiplex testing. But yes, of course, testing, I think, should become much more common.
Thank you. And another comment and question, Dr. Block, thank you so much for the great way of explaining these complex topics. I struggle to provide an answer to why hepatitis C treatment / cure were easier, quicker. Do you have a simpler way of answering that? It sounds like, oh yeah, go ahead.
Well, I think there are two answers. The stock answer is, hepatitis C it's called an RNA virus. It's cytoplasmic. It can't set up this kind of enduring DNA. It can't get into the nucleus. That's the party answer, the party line answer. The real answer is, what are you kidding? Much more money was put into hepatitis C than hepatitis B. I mean, we had to, look at COVID was cured. The vaccine was developed within 9 months. We've never had anything like that. Well, I mean, there's no question in my mind that with enough money, you would get a cure for a real cure for hepatitis B faster. I don't think there's any reason why. We see you can cure 10, 12% of the people right now. So I think it's the money and the effort, and that's not going to change dramatically. So yes, I think that hepatitis C, it turns out, there are some virological reasons why it's easier. But up until it was cured, and by the way, I know that's really kind of almost insulting to people like Mike Sophia and Mingao, who developed a cure for hepatitis C, when everyone says, "Oh, that was an easier virus to cure." It wasn't. It wasn't. It was hard to grow it. It was hard to they had to struggle with that. It's that you put enough time and effort into it, you can cure it. Looking back, you say, "Oh yeah, it only grows in the cytoplasm." It's there's some virological reasons. No, I think that put more money, more time into B, and you'll cure it.
Thank you. And Dr. Rutland asks, with the advent of siRNAs, will it be reasonable to even treat those with a core positive and inactive virus?
Yeah, great question. By inactive, if you mean S antigen positive, to be fair to the really conservative and careful, I guess, evidence-based professionals on the call, there is not yet a strong evidence-based double-blind clinical trial to justify treating some of those populations. Remember, I put up the slide from the Kim paper that shows there's, I think, an epidemiological rationale saying, hey, these people in the immune tolerant phase and the inactive phase need some kind of attention, because they're at a significant risk, a lot higher than I think people realize, of decompensation or of cancer. It's not a risk like people in immune active. That's a no-brainer. That was the 30-40% chance of dying in 10 years. But it's a risk level more like that of people with hypercholesterolemia who you treat with Lipitor or high blood pressure. But in answer to the doctor's question, there will now be, I would say, a virological justification, because you'll have a drug that will suppress every gene product. But I must be honest, there is as yet not, and there may never be, a double-blind study that the 3 to 5 year double-blind study to show that treating that group with siRNA really does have a benefit. It's going to have to get into an area of what I call expert judgment, like what the rest of us call common sense. That there's a virus in the person. It's growing. If you have a safe drug, you can repress the antigenemia then maybe you'll reduce the risk.
Thank you. And then the next question, in the wake of universal screening guidelines, how widespread do you feel access to testing can be, or do you feel it will be limited to hospitals and primary care?
I didn't understand in the like, you mean when there's universal guidelines, universal recommendations for testing everybody?
Correct.
I'm hoping that comes along with some guidance on how that's to be implemented. It was for C. So, and the tools will be, and awareness will be made available to all primary care providers, not just specialists and not just physicians, but anyone out there who is going to be at the portal of entry for all care, anyone who's seeing a doctor.
Definitely. And just a note as well, it's our understanding that we should have hopefully some update on those guidelines by the end of the year or early next year as well. So,
and you would know that, Catherine, better than me.
Yeah, and we'll be sure that may be one of the first ECHO sessions, hopefully, if all goes according to the universal way of screening for hepatitis B one time for adults. Hopefully that might be one of our first ECHO sessions in the new year.
Terrific.
Next question, what will the treatment course look like in terms of length of treatment, side effects, time to cure, or will it be similar to the current treatments that are indefinite or suppressive?
Thank you. Well, the goal is, of course, limited duration treatment. That's the goal. For the siRNAs, they seem to have an enduring effect, at least, and the antisense, that GlaxoSmithKline study was quite stunning. I can't remember the name of the study, but it showed that treating, I mean, it's an injection, but treating multiple times at the beginning of treatment, the effect of the siRNA seemed to last for weeks, if not months. Probably repeated treatment would almost certainly be needed for, I don't think anyone's really imagining treatments less than a year. The goal, let's face it, is short term, a short course of therapy. Hepatitis C is our model. The reality is, of the drugs that I say are going to be approved, we're probably talking still probably multi-year, certainly a year of treatment, but maybe not with siRNA daily, maybe episodic, periodic treatment broken in time. The CAMs will almost certainly require daily oral treatment for almost certainly more than a year, and the checkpoint inhibitors, that's not one and done, but that's done over a very short period of time in an initial ramp up of treatment loading.
Thank you. Melissa, I wanted to see if you had any questions or comments from Dr. Block, or any thoughts. Sorry to put you on the spot. See if she's there. She may have stepped away for a minute. That's fine. We'll try to come back to her if she joins again. But I wanted to also ask you, Dr. Block, about treatment expansions and kind of where we are in that discussion, because some of the data that you presented really did demonstrate potentially the justification for treatment expansions. And I also wonder if there's any potential negatives to that as well, just playing the devil's advocate there.
Great question. You mean to expanding the guidelines? Yes. Right. To begin with, here's what people say when they say that expanding the guidelines is unjustified. One, they say there's no, there's no evidence-based study, there's no double-blind clinical trial that shows the benefit of treating someone who's currently outside the guidelines. So yes, maybe they would now agree, because initially I think there was some question about the risk of dying from liver disease of someone who is outside the guidelines. The feeling was that is pretty low. It is low. I don't want to scare anyone, but what I've shown you is it's not zero, and it's significant. So we know that they should be surveyed, but we don't know that any of the drugs that are out there in use today can really be can justify using them based on a clinical study. And that's doubly true for the drugs and the investigational drugs we've talked about. Those studies just aren't being done on that population. So that's the first argument against it. Where's your evidence? Well, it's and what our answer to that is, we don't want to wait. We don't want to wait 10 years. We don't want to wait. There's enough justification. Another argument against it that's used is you're talking about the immunotolerant people. Those are generally the younger people. We're talking about people in their teens, 20s, 30s, even 40s. You're talking about putting these young people on medicines probably for the rest of their lives. Those are the drugs that are approved for use today, the nukes. If you go on them, are those people going to have to go on them forever? Do we really know what the untoward effects of these nukes are after 20, 30 years? The answer is, well, yeah, they're basically the same ones that have been used for HIV. So we do know that, but that's an argument against it. Young people, they don't want to be on drugs. What 25, what 30-year-old wants to start a medicine and be on it for the rest of their lives? So that's an argument against it. They'll go off their drugs. There's an expense involved. You haven't proved to me that it's necessary, and you're going to start paying for this thing at 27 years old. So those are the arguments against it.
Thank you. It's really helpful.
Thank you.
Great. So any other questions or comments for Dr. Block? Any feedback? All right. Thank you so much, Dr. Block. Again, I think this was a really great discussion.
Thank you. Then I want to thank you for the opportunity, Catherine, and I want to thank everyone on the call for having this interest in hepatitis B and D and liver cancer. It means a lot to us, particularly me, having been a part of starting the foundation and seeing it go this time. I can't wait to run downstairs and tell Joan, my wife, who's here, just to see what the activity, the interest that there is for hepatitis B now that there wasn't 30 years ago. So I thank you all for the time and effort, and thank you for the endorsement of the foundation. So with that,
yeah, thank you,
we'll
Dr.
sign
Block.
off. You're welcome. Bye-bye.
Bye. Thank you. So